Fine. So today we are having Dr. Tanima, pediatric physiotherapist from Bangalore, with us. As a kids pediatric physiotherapy clinic has started this YouTube channel long back, and from monologue to dialogue, we have improved a lot. Now today we are going to talk about the types of cerebral palsy. Long back, I had talked with Dr. Riddhish Lania regarding the cerebral palsy and medical management. Now we are having pediatric physiotherapist with us, and we will talk with her regarding the how pediatric physiotherapists are managing cerebral palsy from pediatric physiotherapist point of view. Anima, we just wanted to know from the pediatric point of view, when you are seeing the patient with cerebral palsy, how you are seeing that patient, you are assessing that patient and your treatment. We just wanted to know the brief idea.
Okay, so when a patient comes with a diagnosis of cerebral palsy, we usually look at three main domains. We look at the trunk, as in how is the child managing the gravity, how is the child able to move around with. Now, also along with that, we look at the hand function and we look at the leg function. This is all functional assessments that we do.
So to talk about the functional assessment, so we heard about the GMFCS scale. So what can you tell us about that GMFCS scale?
Yes, it's a functional classification where cerebral palsy kids are classified upon five grades or levels, if I had to put to. So, GMFCS 1 and 2 are kids who are walking, who have a bit of stair climbing with or without support. GMFCS 3 may be walking with a walker or an assistive device. GMFCS 4 and 5 are wheelchair assisted, and 5 is usually bedridden.
Okay, so you would mean to say that GMFCS 1 and 2 are independent and they are least affected, and GMSS 4 and 5 are most affected children.
Yes, we can put it in that way that they're yes.
Fine. So if you can tell, like children those who are having GMFCS 1 and 2 and they are able to walk, but we are able to see the gait problem in that. So can you just little bit elaborate about the gait problems we are able to see in that?
Yes, So the common gait patterns that we see is a toe walking, which toe walking is what we see. Circumductory gait we see, and we see something called as crouch gait.
Okay, so you mean that crouch gait means patients are bending knee and walking?
Yes.
And circumductory, we can see usually in hemiplegic patient when
Yes.
hand is bending and they are doing
yes.
circumduction and they are just rotating their hip when they are
Yes.
walking. And tiptoe means children are walking
Yes,
on
on
their
toes.
toes and
Yes.
heel are raised.
Yes.
So as a physiotherapist, how do you manage that gait?
There are many ways. As physios, we do a lot of exercises. There's a lot of training that goes into it. We use external devices such as orthoses to manage their muscle tightness. And as physios, what we do is something known as serial casting to get a good range for the muscle to act optimally.
So can you elaborate a little bit about orthosis use in gait?
Right. So orthosis is an external device which is used to support an injured limb or a weakened limb. I would put it in that way. And there are many orthoses available for your upper extremities and lower extremities. Since we are talking on gait, we will stick to lower extremities. Right from your ankle to your hip, we have external devices that help the child walk. These devices are again customized as per the child's muscle range and then given as per the need.
Fine. So I think what I learned from all the years of experience is how do they take assessment orthotic person and how do they make the orthosis make sense. It makes difference than someone who are making this orthosis without any measurement, just making measurement on paper and measure tape. Am I right in that perspective?
Yes, I think it's wise enough to get it done by an orthotist. We usually, if I had to elaborate on this, we usually get the ankle range, and based on the ankle range, if I had to talk about ankle foot orthosis, which is commonly known as AFOs, we usually measure the ankle range, and based upon the ankle range is what the AFOs is being prescribed. Also, typically we here look at managing the arches of the foot inside the AFO as well. So yes, it is advisable to get it done with a qualified orthotist.
Fine. So what message she has conveyed it, when your child is getting treated by any of the pediatric physiotherapists, and definitely those who are pediatric physiotherapists are going to see that how your child is getting improved in the term of gait, what orthosis is needed, they are going to talk with good orthotic person and they are making that orthosis which is need of your child. So along with therapy, this orthosis is needed to make your child independent, or to restrict their deformity, or to make them walk independently without any problems. So thank you for your sharing your insight, and we are grateful. We'll be having this other session soon. Fine, thank you very much.
Thank you for having me.